Hello everybody and welcome to today's webinar. My name is Kate Halliday. I'm the Executive Director of Addiction Professionals. I'm so pleased to be introducing this webinar today. It's a joint webinar between ourselves and Adfam, but I'm also really pleased to introduce Public Health England Virginia Wright. She's the Parents, Carers and Family Lead, and the basis of this webinar is to look at some resources and also some guidance that's been developed looking at parents with drug and alcohol problems. And it's looking very much at supporting services and also commissioners in how to provide the best interventions. This webinar is being recorded, so you can watch it again if there's something you want to revisit. And also, it's been very popular, this webinar, so there's quite a lot of people watching it. We're going to encourage you to put in comments and chat in the chat function and the questions and answers function. And the structure of the webinar is that Virginia is going to speak for around half an hour. We've then got another speaker, Philip Breslin from Adfam, and he's going to talk for around 10 minutes. And looking at issues for commissioners, and then there'll be a chance for questions and answers, and I'll do my best to put those to our presenters at the end of the webinar. And with no further ado, that is certainly enough from me. I'd like to introduce Virginia Wright to talk through some of the resources and guidance.
Thank you so much, Kate, and thank you everyone for taking part in this webinar today. So as Kate said, I'm Virginia Wright. I am the Programme Manager in Public Health England, responsible for parents, carers and families that are affected by parental alcohol and drug use. As we've got quite a varied group on the call today, I'm going to spend some time sort of discussing prevalence, support needs and harms associated with parental alcohol and drug use. So that everyone's kind of, on the same page, before then going on to some of national treatment data on parents receiving alcohol and drug treatment from the National Drug Treatment Monitoring System database, or NDTMS. I will then talk you through work that we've done using case studies to estimate the social cost benefit of working with families affected by parental substance misuse, before sort of finishing off with what can be done locally to improve the support given to sort of vulnerable families. Throughout the presentation, I'll be making reference to the recent resources that we published, and I will summarise these again at the end, as well as promoting some sort of forthcoming webinars and even more webinars that might be of interest to you. So as I set the scene and discuss prevalence and harm, I'm going to be showing you slides from my recently published evidence slide pack, an example which is here. So to kick things off, according to data from Children's Commissioner for England, in an average secondary school, there are 40 pupils who live with a parent with an alcohol or drug problem, 9 of whom will also be experiencing, co-occurring domestic abuse and parental severe mental health problems. According to Department for Education statistics on child in need assessments by social workers, parental alcohol is recorded as an issue in around 16% or 1 in 6 assessments, with roughly the same proportion recorded for parental drug use. I think it's 17% as a factor. And also the NSPCC receive sort of pre-pandemic calls, around 200 calls and emails a week related to parental alcohol or drug use, which during the pandemic and during lockdowns actually increased to around 66%. Unfortunately, substance misuse is prevalent in deaths of mothers within the first year of giving birth, and it also features, not surprisingly, but rather unfortunately, regularly in serious case reviews where a child has died or has been seriously harmed. And just to say, actually, that in terms of all the sort of stats and evidence things that I'm referring to, in the actual original slide pack, there are references to all of these. So we have links on each slide. You can access these links and you can access all the references. Everything we're saying here today is evidence-based and is supported by data and studies. So Not surprisingly, parental substance misuse is sort of very rarely just the sole problem that families are experiencing. Typically, there'll be other issues, for example, mental health, abuse, parental separation. So these are, kind of complex families that often need more support than just around parental substance misuse. But I guess, kind of these are all sort of indicators of harm, but what exactly are the risks? And so the first thing to stress really is that not every child growing up in a household where a parent is misusing or, dependent on drugs or alcohol will experience harm. But for those that do, there can be an impact, and that can sort of affect them throughout the life course. We've got sort of from impaired brain development, low birth weight and withdrawal symptoms after birth for those who are exposed to substances during pregnancy, to children then sort of taking on the role of carers, for their parents or their siblings when they're that bit older. There's also strong evidence of children developing internalizing and externalizing behaviours, as well as sort of poor educational attendance and attainment, increased likelihoods of getting into gangs as well. So yeah, all these things that, not only impact on their childhood, but obviously would be things that will sort of affect them into adulthood as well. And of course, there's strong evidence that left untreated, where there is parental substance misuse, the children of parents who misuse alcohol and drugs can go on to do so themselves, and that kind of cycle of vulnerability continues. But the literature does point out sort of several protective factors that make it less likely for children to experience harm where their parents are using or misusing, alcohol and drugs. These include, but aren't necessarily limited to, the personality of the child, sort of family stability, there being sort of close positive bonds with other, adults, and also, the parents receiving treatment for alcohol or drug problems seems to be a real sort of protective factor. Now in PHE, or Public Health England, we hold the National Drug Treatment Monitoring System, NDTMS, which is a huge database of most people receiving treatment in the country. And the following slides will take us through some of that data that we recently published in our reports. So parents make up around sort of 50% of people starting treatment each year. There still seems to be a real sort of unmet treatment support need for many. So around 80% we estimate of parents with an alcohol, by parents here I mean adults that are living with children with an alcohol dependency are not receiving treatment, and just under 60% with an opiate dependency, so mainly heroin, we estimate not to be receiving treatment. So that's a huge unmet need. Looking specifically at those that are in treatment, we find that about a third of our treatment population are parents that aren't living with children, and 20% or so are parents or carers that live with children. And I think that's quite an important distinction to make, because I think often when we're talking about parents, we are sort of thinking about those that live with children, but there are quite a substantial number in the treatment system that aren't living with their children. And when you look at their data, this group of parents are, really distinct from those that do live with their children and non-parents. They're a lot more complicated, have most sort of complex support needs, and particularly vulnerable. So they're more likely to be heroin users, have coexisting mental health problems, to be injecting, to have been brought into treatment via the criminal justice system, be at risk of homelessness, be unemployed or on sort of long-term disability allowance. And not surprisingly, given that kind of level of complexity, they are less likely to complete treatment successfully, and they're more likely to require further treatment down the line when they do sort of leave treatment. Conversely, parents or carers living with children do seem to be sort of far less complex and thankfully sort of more likely to complete treatment successfully than most groups. As well as the kind of, treatment data, within NDTMS, since April 2017, we started recording data on early health and social care, or specifically child social care, that's, also have additional support that parents in treatment might be receiving. Perhaps not that surprisingly, the data tells us that parents or carers living with children are more likely to receive the kind of early help support or have a child on a child in need plan. But the data also tells us that parents that are not living with children are kind of far more likely to have a child looked after. So while they might not be living with their child, it might be because their child's actually being looked after by the state. So alongside, the treatment data, the structured treatment data, so your psychosocial and your pharmacological interventions, we also report kind of recovery support interventions that can be happening alongside structured treatment or after treatment to kind of, encourage recovery and to support recovery. And we know from analysis that increases the likelihood of completing treatment successfully and to not coming back into treatment. And a recent review by Ruth McGovern and colleagues showed that the effectiveness of psychosocial treatment when incorporating sort of parenting skills into the treatment programme had the most effect on reduction in parental alcohol or drug use. So in NDTMS, we can kind of capture that a little bit. So we have sort of family and parenting recovery support, and we can see that actually the proportions of people receiving or parents receiving those types of interventions are pretty low. And for those that aren't living with children, they're even lower, despite the fact that, if they do have children in care and they are in regular contact with children, although they're not necessarily living with their children, they might actually sort of need that additional support. So that's, kind of high level talk through of what data is available and to give you an indication of what parents look like in the treatment system. There's a lot of other data available in our data reports, which I would encourage you to have a look at. Obviously everything I presented here is sort of a national level, but we do have local level prevalence estimates and estimates of unmet treatment need. We have sort of NDTMS socio-demographic, clinical and outcomes data. And what local authorities are able to do is also to compare their data, not just with the national picture, but also to kind of similar benchmark areas. So it's a CIPFA benchmark areas, and if you go on to the website, you'll be able to see, which areas you're being compared against. But it's essentially areas that are similar to you in terms of, things like deprivation, etc. We also have data that we present around sort of parents under 18 years old, as well as young people that are living with other siblings who are in treatment for drug or alcohol use. And as well as the kind of NDTMS data, we also have data from the child in needs assessments, and that's trend data that you can have a look at, and again sort of look at your local data and compare yourself to benchmark and national data, as well as the sort of estimates that I was alluding to at the beginning around co-occurring parental substance misuse, mental ill health and domestic abuse. So there's a lot there to have a look at, which I would encourage you to do. But before we sort of move on to the kind of case studies, while we're still talking about data, I guess there are a couple of points I want to reflect on regarding what I've shown you so far. Our understanding of the effectiveness of treatment for parents is only as good as the data that's recorded on NDTMS. So every person coming into treatment should be asked about their parental responsibilities, and also this should be sort of regularly reviewed, because obviously parental responsibilities do change, and there is, and this information should be sort of recorded and revised when it needs to be. And ideally, this would all be on NDTMS, so we can sort of capture that at the national level and improve our understanding of parental responsibilities among the treatment population. Parenting capacity should obviously be explored when dealing with parents in the treatment system. And, where possible, kind of parents or carers should be referred to a parenting support worker as part of their recovery support package, because we know that that does increase chances of success. And that will benefit, not just the parent, but obviously children and the whole sort of family involved. And hopefully what I've kind of demonstrated, albeit very quickly, is to kind of not forget parents that, don't live with their children too. And they are a particularly sort of vulnerable and complex group that may be needing, a lot more support in terms of, getting back into contact with their family or around parenting, etc. And that we shouldn't assume that, they don't necessarily have any contact with their children just because they don't live with the children. And again, lastly, I'd encourage you to kind of, go on to NDTMS, have a look at your data, because it may present a different picture to the national one that I've presented, and it may help you improve, as sort of identify areas of improvement. So next section, excuse me, is around value for money. So the data tells us that treatment is effective in improving outcomes for people, though some groups do better than others. But what do we know around sort of value for money of treatment? So I'm a trained economist and have spent many years sort of looking at the economic benefits of treatment, and treatment specifically for everyone, not just parents. And we've been sort of very lucky in that we can make a strong economic case for treatment, because there have been so many sort of studies looking at treatment as a whole, looking at sort of mortality, as well as crime reductions and health improvements, etc. And also, we have a massive database in NDTMS that we can match to other data sets like the Police National Computer, and we can sort of track, people who are committing crime before they enter treatment. How did their offending behaviour change? Thankfully, it mostly reduces, and therefore you can, attach a cost to that. But where there's always been sort of issues is around sort of savings to the local authority, which is a problem because it's the local authority that actually, funds treatment. But we've always sort of struggled to make a really strong case around savings for, education, housing, and of course, social care. And that's particularly true of sort of families as well, because obviously when we're talking about children and we're bringing them into the picture and not just the individual receiving the treatment, then it's largely sort of local authority savings from that perspective that are going to be achieved. There aren't any economic studies that I can use really to be able to make that sort of economic case for interventions with parents and families. What exists usually are around, sort of RCTs around of specific interventions that aren't necessarily delivered across the country, so not really representative, as great as they are. And also, there's no national data set that I can match, or I say like me, some clever person in the analytical team could match with our NDTMS data. We're just not able to do that. So I wanted to be able to demonstrate that, it's definitely worth something. It's definitely worth doing. Investing in families is important, and parental substance misuse, as I've indicated, is a real issue, and there are harms associated with it. So I started thinking about potentially using case studies. Drug and alcohol services seem to kind of regularly collect, not necessarily regularly, but have been collecting case studies as a way of demonstrating the benefits of their service and how their service and their intervention can really sort of positively impact parents and children. And so I asked for a few sort of case studies from providers and areas across the country, and realised that there were sort of common approaches to collecting the case studies, and there were sort of common themes that were coming up again and again and again that actually we could monetize, for want of a better phrase. So attach a unit cost to. And in particular, we could do that with the LA costs, which were which are the things that we've been missing for so long. So we've used this sort of case study approach and, sort of run with it really and developed it. And we have these in our slide pack. So an example here is from the case studies, and in the slide pack. In the slide pack, we have sort of 4 different distinct families. They're all real. The names have been anonymized, and there's no chance of knowing who they are. But they're sort of all distinct, but they kind of have familiar themes coming up again and again, and so they'll hopefully be kind of recognizable to people. And the idea is that we can, demonstrate from all these different types of studies and kind of complexity in terms of families that working with them, has a benefit, and it does create savings for the local authority as well. So I'm only going to go through one of them sort of briefly, because obviously, we don't have a massive amount of time. But this one's a particularly sort of complex case. So it's Jenny and Steve. So Jenny and Steve were both heroin and crack users with a history of domestic abuse. Jenny had children and who were removed from her care. Steve has a significant criminal history, including violent crime. While pregnant, Jenny lived with Steve, surrounded by other drug users, as she was homeless. She wished to separate from Steve to enable her to become drug-free and to care for her child. After the baby's birth, the LA was granted an interim care order. Jenny entered rehab with her baby. Steve also received treatment. They also sort of independently received support around parenting and relationships. And both parents are now separated and kind of remain substance free. Social care is still involved in the case because, as rightly they should be, or at least, sort of shortly after the baby was born, they were still involved to make sure that, Jenny and baby received all the support and care that they needed. So, social care involvement didn't cease entirely, but they're doing a lot better as a couple. And I wanted to show that example because while we do have examples in the case studies of, everything sort of getting so much better and there being no social care involvement, that's not always the case with some of the families that we see. And that's okay. Absolutely, it's okay from what they should be doing, but also it's okay from an economics perspective as well, because you do still see massive savings. So in this example of Jenny and Steve, we estimate kind of local authority avoided costs of around 42,600, and that's net costs in social care and housing savings, or 220 for every £1, and that's in the first year alone. And I've presented it in the slide pack deliberately as a 1-year saving to the local authority, because of the point that it's, the local authorities that are commissioning these services, and also, budgets are tight, people are interested in that kind of immediate saving. But, there's also, you can, and we do know that if you include the kind of wider savings, take into consideration the criminal justice stuff and sort of care proceedings and everything, that there are kind of bigger savings in the short and longer term. So it kind of ranges from about £3 to £4 every pound invested if you take into that wider social and economic savings and benefits. So as I said, in the slide pack, there are kind of 4 examples of distinct but sort of similar in a way families in terms of the themes that come up. And so what I've done to kind of support people with an interest in this is to develop this social cost benefit tool and unit cost database that people can refer to. So you can go into this and have a look at how the case study of Jenny and Steve was calculated, as well as all the other calculations that the other sort of case studies that we present, with the idea that there's a template in there too, so that you can have a go, if you have case studies yourselves, to actually then, do this sort of similar work yourself, work out what the social cost benefit might be. Yes, so So yeah, so it looks like this really. I'm not going to spend, a massive amount of time on this particular bit, but as I said, it will take you through, Jenny and Steve. I don't know how well you can see that, but it starts to highlight exactly the things that you can cost. It's very clear or hopefully clear when you're in the database where these costs have come from. So the unit cost database within it, houses a whole load of costs that are sort of relevant to families that I've been able to find from, sort of looking at the literature and looking at various reports and things but also ones that I thought were the most relevant, bearing in mind the kind of case studies that were being received from local authorities. So there's a whole wealth of information there. And so it will take you through exactly how these were worked out, again with the view so that if you wanted to do something similar locally, you can do. You should have all the guidance that you need to do that. So as we kind of come to the end, I just wanted to stress that, while I've obviously been predominantly focused on treatment and the treatment sector, I think what some of the case studies show, and what we know just from having been in this sort of field for so long, is that in order for us to provide the best support we can, we need to be sort of looking beyond treatment and working together as best we can with other sort of services and systems. There needs to be sort of collaborative assessment at a local level, information sharing and strong pathways. None of this is kind of new, but I think we do still sort of struggle a little bit, and it becomes harder and harder, as budgets get more and more slashed, resources, people's time and caseloads, real challenges, and obviously the pandemic hasn't helped either. But also, yeah, we need kind of skilled and capable frontline staff, but also there needs to be sort of senior leadership effort, I think, in developing that whole system response. To kind of support that, we've written planning and operational guidance aimed primarily at the treatment and children and family sector as well, about kind of working together. As you would expect, it brings together sort of statutory guidance, in terms of your, safeguarding responsibilities, etc., particularly at a treatment level. But also in there are sort of learning from studies, academic studies, and, significantly from areas that have been doing a lot of work in this space. In particular, the areas that we fund that we support as part of the Children of Alcohol Dependent programme. We've sort of put that in there to kind of show, to support people in sort of delivering services locally and sort of working together across sectors. There's a lot in there which I would encourage you to take a look at when you can, preferably, ideally, after you've had a look at your data, see where you are in terms of parental unmet need and sort of understanding of the people in your treatment system. Have a look at this to see what could be done locally potentially to kind of help support vulnerable families more. So there's a lot of resources out there. So we've got the evidence slide pack. So the sort of more fancy slides are directly taken from the slide pack. As I said, there's loads of references in there, so you can have a look at the original sources of all the numbers and things that we present. And also I'd encourage you to take these slides and use them and adapt them as you need to. So the link to everything is in this presentation, which I'm happy to share after this event. So we've got the evidence slide pack, we have the data reports from ndtms.net. We have our Investing in Families toolkit, which is showing how you can use case studies in order to estimate the social cost benefit of working with families. So that's the database, there's a guidance, and also the case studies that we present in the slide pack. And there's the planning and operational guidance, which I've just discussed now. Got links here. Oh no, there are links. And then before I go, just to kind of promote kind of our forthcoming webinars. So if you are interested in knowing more about the Investing in Families Toolkit, we've got a webinar next week where we'll be sort of, focusing on that. And obviously I'll be there speaking a little bit, but more importantly and more interestingly, there'll be two guests, so Louise Bolton from the Society of St James and Rachel Taylor from CGL, who'll be sort of talking about their experiences of getting case studies, and Rachel will be talking about her experience of actually using the toolkit and how it's helped her, and how they'll be using it in CGL going forward, which may be of interest. You need to register, and there's a link to there. And then the week after, it's a busy month of webinars. We are also doing a webinar as part of the Children of Our Co-Dependent Parents programme about the increase in parental drinking since the pandemic, which may also be of interest. But as I said, I'm happy for these slides to be shared, and you'll have all the links and everything to these. Those are my contact details. The last link is a link to our Knowledge Hub. So we have a Knowledge Hub dedicated to parental alcohol and drug use. If you become a member, you'll get a newsletter around all the sort of webinars that are coming up, and sort of publications and government documents. And also, it's a space for people to kind of share best practice and ideas, and to also ask questions of sort of like-minded individuals who might be able to sort of support them in this sort of on this issue. And that's it from me.
Fantastic. Thank you so much, Virginia. That is great. We've got lots of comments saying thanks for that information. A lot of really useful guidance there. You've answered one of the most common questions, which is, can we have your slides?
Yes.
So that's great. And what we'll do, this webinar will appear on our website sometime next week, and we'll include the slides in the space below the webinar so people can access these slides. And we'll also put some of those links to the various webinars and guidance as well.
Thank you, that's wonderful.
Also, just to let you know, we've got someone here from Indonesia watching, so we're
wow, international.
I was wondering, before we go on to Philip, I was wondering whether you'd have time just to answer a couple of questions. And then
yeah, sure.
Okay, so someone's asking, what data do you have on the hidden harms of people on prescribed dependence-forming medications? Often the parent has chronic physical and or psychological illness, with the children providing sometimes age inappropriate care of the parent.
I'm not, so certainly in terms of the NDTMS data, we don't have anything that breaks it down in that way. I'm not sure if there is anything out there in terms of the academic literature either. There's nothing that kind of immediately springs to mind. So I think it's, unfortunately, it's really sort of under-researched area. We don't break down the data in terms of reporting on NDTMS. So unfortunately, we just don't have that information.
Okay, thank you. I just had a question as well for people who are watching. Perhaps you've mentioned the local level data. Could you just say where people could access that if they're not sure?
So the local level data is from ndtms.net. I have my own sort of page there now, parental substance misuse, and on there you'll see it's presented by a regional level. There's a whole load of reports, but you can click on any local authority report and you'll see the same sort of setup. You'll have the national picture at the beginning and then your local specific data. There's technical support there too, and kind of more detail around how things are calculated if people are really interested. But I definitely recommend it. It's very sort of interactive. You can sort of zoom in and out and take present the tables and graphs in a slightly different way and adapt it which is helpful when you're doing presentations like this one. So it's a good resource that we're hoping to update every year.
Thank you. So maybe we could provide a link for that as well.
Links to everything it's on there on the slides, but happy to send them out as well in a different way.
Thanks. And then maybe one more question, and sorry that there's more questions coming through, but hopefully we'll get around to those once Phil has spoken. In young people referred to CAMS, parental substance misuse is a significant factor, but usually only identified in retrospect. Is this your experience? It sounds like it's the experience of the person asking the question. And if so, any ideas why that might be the case?
I think often when services, so in particular, not necessarily, start again. I think there might be an issue where people are sort of dealing with the problem that's immediately in front of them. So CAMS, it might be sort of thinking about the sort of immediate issues that are faced or that are presenting in terms of the child or young person that's there, and then parental substance misuse might then come up sort of further down the line, but it's not that immediate sort of presenting issue. Potentially, I think that's the sort of thing that comes up across different sectors where parental substance misuse might be identified sort of later on. I don't know enough about CAMS to know whether it's that kind of part of that routine sort of question, in the same way that within the adult treatment sector we would be expecting people to be asking around parental substance misuse. Yes, when you're talking about a child and the sort of data that's recorded on them from CAMS, it might not be necessary to record it straight away or to ask those questions. I guess it's part of our responsibility to kind of wherever we can, with all the professionals that we speak to kind of bang the drum about parental substance misuse, and to kind of think about those wider issues, and to not just think about the problem that's necessarily presenting itself, but to try and sort of understand what else is going on that might be affecting the child. There are lots of I'd recommend having a look at the slide pack around sort of evidence around parental substance misuse and the impact that it has on the child. But yeah.
That's great. Thank you so much, Virginia. And I'm really pleased now to introduce our second speaker. Phil Breslin works with Adfam with a specific role looking at working with commissioners. And he's going to talk a little bit about how the resources and guidance can hopefully be implemented. So over to you, Phil.
Hello, everybody. Hi. I hope you can see me. I've thrown as much light on me as possible. I was told earlier I look a bit like a Bond villain emerging from the shadows. So if that's all you can see and just hear my voice, sorry about that. As Kate was saying, I'm doing some work with Adfam and specifically around commissioning, substance misuse commissioning, which is my background. I realise there's a few, I think 14, 15 commissioners on the call. So don't worry, I've got your back today. I'm not going to be blaming the commissioners for things that aren't being done. I think it's an incredibly difficult ask, actually, this for substance misuse commissioners. I have to say from the outset, I think it's a really good piece of work. I've been looking through the documents that Virginia's been working on and released, and I think there's some just great stuff in there. As with all really good pieces of work, it raises some challenges for us, I think, as it should. The work that I've been doing with commissioners recently has highlighted just how busy substance misuse commissioners are, and they would be the people who would routinely be expected to be directing the spending in this area. They have been pulled onto lots of other pieces of work to do with COVID, unsurprisingly. They do support family work, and family work is going on. Family work linked to substance misuse is going on around the UK at the moment, even where other pieces of work have been cut back. But I think it's not the mainstay of their work, and they have all struggled to maintain the services that they have, given the shrinking budgets and the demands and some of the shifting demands. So I don't think this is something that we can just turn to substance misuse commissioners and say, these documents have landed, you now need to do something about it. The demand has been evidenced, the cost savings are there, and now we'll look to you. I think Virginia was put up a great slide that had lots of different partners in the piece, and I think this is something where we have to look to others to take responsibility alongside the substance misuse sector broadly and alongside substance misuse commissioners in particular. The difficulty, I suppose, and nobody will be surprised to hear this, is that we in local government certainly, and in other parts of local and regional government and in clinical commissioning groups, we love to work in a silo, and everybody loves to benefit from somebody else's spending, but we're always very reluctant to commit any of our own funds to this. And I think substance misuse commissioners are working with fixed budgets, and if they're to commit more money to this area of work, then they are going to have to cut back on something else within their portfolio. So there are some very difficult choices, and I'm going to come back to something about that collaborative working. But I also wanted to just say something about how the treatment system is at the moment, and I think it's very interesting to hear that 50% of people in treatment who are parents and 20% are living with children, because my experience from looking at a lot of services around England and having commissioned lots of services is that we are focused on individuals and not family. That's our organising principle, is the individual, and that our time and our energy and our resources are very much concentrated on the clinical end. And if we look at the treatment profiles, we see lots of people who've been in treatment for a long time, in their 30s to late 50s, opiate users, high-end alcohol users, and those people take up a lot of the resourcing and the funding that's available. And I think the responses to COVID have probably consolidated that, because we have been looking at funding coming in around drug-related deaths, around rough sleepers, and that's absolutely understandable. But that is that group of people again. And I think this release of documents shines a light on another area, on the substance misuse that takes place within the family. And I think there can be some characteristics of that's a challenge to us, to our treatment systems as they're set up, because we may find that the drug and alcohol use that we're uncovering may in many cases be at a lower level than we're used to seeing within treatment services, but the impact is very, very high, and those impacts spread far beyond the individual. And I'm not sure that our treatment services have been set up to work with that, actually. And I made a note of some of the figures that Virginia was giving us, and the pupils in school where there was parental substance misuse. And I was wondering how many of those parents, actually, where that is the case, how many of those parents would go near a drug or alcohol treatment service? Is it recognised as a drug or alcohol treatment issue? And if they did go near a drug and alcohol treatment service, although the barriers to drug and alcohol treatment are very low, would it be something that we would feel we had a suitable response to? And I also looked at the 1 in 6 child in need assessments where parental alcohol use was a factor. I don't know if drug use was in there as well, but parental alcohol use was mentioned. That seems to me to be really low, and that's borne out by some work I've done recently with local areas where they have dipped into their social worker caseloads for child in need, and they found in one area they looked at 100 cases, and they found that 70 cases mentioned substance misuse, and about 7 had actually been referred to a treatment service. And that seems to be anecdotally because the social workers don't have a lot of training around substance misuse, and they don't feel confident about sending their family to a substance misuse treatment service, which they feel is set up to work with high-end opiate use, crack use, high levels of alcohol use, and not for the sorts of families that they're working with. I was also doing some work somewhere else and talking to an early help lead, so a troubled families style intervention. And I said, does it come up a lot in your caseload, substance misuse? And they said, all the time. All the time. It's all the, almost all the cases they get, certainly all the cases they refer on. And I think the timing of this is fascinating, because today the care review, the first part of the care review, led by Josh McAllister, has come out. And it seems to be that the takeaway from that is that we over-assess and under-intervene. And by intervene, I mean provide interventions. We assess a lot, and lots of cases go into the children in need part of the system, but there is not a lot of intervention to help people. And once you get into that children in need system, there's a lot of stigma, and we know the stigma that exists already for parents around substance misuse and for families around substance misuse. And so I think the ask, at least in this first part of the care review, is that we need to look at a system that provides support and intervention to people that isn't stigmatising. And that seems to me that means that we need to work across substance misuse and with those other partners that Virginia was mentioning. And the savings here, I think, and the expertise lies with children's services, and the expertise in terms of the drug use and the family work is with Adfam, and the drug use is with Adfam and other bits of the substance misuse sector. And it seems to me we need to build those bridges, and some areas are doing that. And there is perhaps an opportunity provided by the family hubs, which is going to be the doorway, the government see that as the doorway through which families can get a range of services they need. It is perhaps there that we will be able to break down the silos and genuinely fund services that work for families as opposed to services that work for individuals. But there's loads of expertise in the room. There's hundreds of you out there working in this field. So I'd be very interested to see your comments, and obviously if there are any questions that you have for Virginia or myself. Thank you.
Great, thank you, Phil. And we do have quite a lot of questions and comments, so I'm going to start off by asking you as a panel. Hi, Virginia. Someone says they work as a specialist midwife and they're overwhelmed with people who are pregnant, I guess, cannabis use, but feel that it's quite often minimised by professionals despite the big risks involved. And they're saying research would be really welcome here, and I guess it's a comment, but do either of you know of any research or anything that could help in that situation?
There's emerging research, primarily from kind of Canada and the US, because kind of relaxations they have around sort of cannabis misuse generally. So there is stuff out there. It is mixed in terms of the impact it has on the fetus. But yes, I agree that there is a kind of it's not necessarily dismissed, but not taken as potentially as seriously. There are guidelines which I can kind of send links to around, discussions with pregnant women around substance misuse that might be helpful. And in terms of the literature and academic studies, it is out there. There's quite a lot of stuff coming in reasonably regularly. I say a lot. Some stuff coming in reasonably regularly in Addictions, one of the journals that might be worth looking at. But yeah, the evidence is just really mixed at the moment in terms of harm.
Thank you. And there's somebody who's made the point that they find it difficult. This is somebody who's a social worker working in a local authority child protection team, saying they find it difficult to encourage people to discuss these issues. You know, they would like to provide support but find it difficult to actually engage with people. There's a kind of add-on comment, I think, to this, is saying, are we perhaps not offering the help in the right way? Is there a stance that can be used when trying to offer help? So I don't know.
I mean, I guess there's quite a lot to unpack there. There is the guidance that's available that I'd recommend you looking at, but I think as a kind of immediate thing, I guess it's kind of reaching out to local drug and alcohol services in your area. You know, they're the experts, and they can kind of, you know, give you advice and support around whether or not, you know, a referral to treatment is needed and the sort of things to be looking out for. I don't know, Phil, if you've got any. Oh, yeah, he's got his hand up. We want to add to that.
Well, I was going to say there are some services that have developed during the pandemic, which I think people find less. They find easier to access because they're online. So there's Adfam have an Adfam at home service, which is counselling that's free at the point of use for families, and other services as well. Other big providers have put stuff online, and I think there is something about lowering the stigma and perhaps looking at some of these online options. They've got very expert over the last year in how to safely deliver work online, which used to be delivered face to face, but often people don't want to go through the front door of a quite intimidating, what can be quite intimidating, drug and alcohol service. So I think there are some good resources for families, but it is an issue. It appears to be an issue across the board, actually, for people.
Thank you. And we've got a question here about, are there any specific services commissioned to support children impacted by parental imprisonment as a result of the substance use?
Well, we're working and supporting with 5 boroughs in Manchester who's specifically looking at that. In particular, the kind of support from you know, going into from prisons into the community, and you know, and the support for families around that. So there is stuff out there. There's not a lot, but we are certainly working in Manchester as part of the children of alcohol dependent programs on that issue.
Great, thank you. I think this is a comment rather than a question, but you might want to add to it, which is training in this area should be compulsory for statutory services. And I mean, I'm personally a trained social worker, and I don't remember doing anything on drug and alcohol use in my training. I think things have improved a bit. They say in Nottingham, they're saying that it's not the case. And they feel that that's why there are low referrals for hidden harm. So I guess what they're saying is people don't necessarily know how to assess for this.
Yeah, I mean, where areas are working well together, it's not just training, but it's kind of joint training. So the joint training of adult or sort of treatment sector and children and family services as well, you know, kind of getting to know each other and asking those, you know, questions about each other's services as well, because, you know, there's a potentially sort of, you know, a lack of sort of awareness or kind of fear that, you know, social workers themselves might not feel sort of equipped to deal with substance misuse, but also on the other side in the treatment sector, you know, staff feeling like they don't want to sort of start asking those questions around, you know, what's going on at home in terms of kids, because then if there are potential safeguarding issues, you know, what do I do with that kind of information? So if where we can, getting them in a room together and having those joint training sessions do seem to work really well, but obviously for that to happen you kind of need sort of, you know, people, the sort of you know, the leaders in the local authority to be able to support that kind of thing. What also does work quite well is having sort of treatment services put into assessments, you know, so, you know, in the multi-agency safeguarding hubs, for example, having members of the treatment sector there to kind of help with assessments has been quite successful as well.
Great, thank you. And I think, Phil, you want to add something?
Yes, I was just going to say that I think just supporting Virginia's point, is that the treatment, so large parts of the treatment sector are used to working with individuals and not families. And they often have one worker or two workers who get skilled up in family work. And I don't think that's enough to address this agenda. And I think that the social workers, are being left to deal with very complex substance misuse issues, actually, without the support always that they would, that they would benefit from, and that the families would benefit on. So I think there is a huge piece of work that needs to be done here. I would just add, I don't think it's going to be, in order to fit with the Family Hub's agenda and with the care review that's come out today, I don't think this is necessarily going to be at the higher end of things. And by higher end, I mean child protection issues. I think there's a massive piece of work which is way below that, which is these big caseloads for troubled families and early help, where substance misuse, mental health and domestic abuse are coming up all the time. And there isn't the support there because our treatment systems are at the higher end, and a lot of the drug use can be at the lower end. And it's about that complicated piece of work. How do you work with families where there's low levels of drug and alcohol use, but they're having a really high impact? And I think that's complex, and it needs us all to be working together. But as Virginia says, it needs the leadership to take the agenda forward.
Thank you. And in fact, you've kind of led us on, because there's a few people who've been asking about mental health, and you've made that point there, Phil, basically saying that there seems to be a lot of issues not simply with drug and alcohol use, but actually dual diagnosis, people with both. You've made a call there, Phil, for working together. I don't know whether anything has come up in your resource pack or anything around this, Virginia, in terms of mental health issues.
Well, we know it features highly in terms of, it's very rarely that parental substance misuse is the sole issue that families dealing with, as I kind of alluded to in the slides. Parental severe mental health problems does feature quite heavily too. It also features in serious case reviews, the coexisting domestic abuse, mental health and substance misuse. Yes, so we certainly have a lot of stats on it. We have prevalence estimates on it in terms of local authority level. But what we're not as strong yet, I think, is establishing those relationships with the mental health sector, so that we do work as collaboratively as we can. It's been an issue for years, as has that kind of the link up between children's sector and the adult treatment sector generally. But it's a work in progress.
Well, I think that's all we've got time for. Sorry, we haven't got round to asking, and I haven't got round to asking all the questions, so apologies for people out there. We do have an awful lot of people on this webinar. That just leaves me to thank you both, Phil and Virginia, for your presentations. Really great information. And also to thank everyone who has been watching and contributing. There's been a lot going on in the chat, lots of great questions. So thanks very much, everybody. And we'll get this webinar up on the Addiction Professionals website next week with all the various links.